In this final video on vaccines, we will be reviewing the side effects of the vaccines, the duration of their effectiveness in protecting against infections with SARS CoV-2, and the current recommendations for booster shots. What about side effects? As this figure shows, mild to moderate systemic side effects are common following vaccination and include fatigue and headaches and muscle aches. These symptoms, as well as chills and fever, are more common after the second injection, but usually resolve within 48 to 72 hours. They are indicative of a strong immune response. Serious side effects are rare with the mRNA vaccines. During their trial, a few recipients developed swollen lymph nodes under their arms, axillary adenopathy. Following the phase 3 trials, the most common serious reaction has been anaphylactic or immediate hypersensitivity reactions. Symptoms can include tightness of the throat, shortness of breath, lightheadedness, and low blood pressure. The incidence is very low, 4.7 per million for Pfizer vaccine and 2.5 per million for Moderna. In the majority of cases, this reaction occurs within 15 to 30 minutes of receiving the vaccine, and nearly all cases have been described in females with a history of frequent allergic reactions to other vaccines as well as medications. For this unique group, vaccination should only be administered in a healthcare facility with appropriate emergency personnel. A major problem arises when millions of individuals are vaccinated in a short period of time. Normal background health issues are interpreted as being caused by the vaccine. Background events must always be subtracted in order to get an accurate assessment of toxicity. Look at this figure. Each black vertical line is a background event, such as heart attack, sudden death, or stroke. The vaccination events are represented by red vertical lines. If a vaccination event occurs right before a background health event, as shown for vaccinations 4 and 5, those who don't understand how to analyze vaccine toxicity will interpret these events as being caused by the vaccine. Remember, just because a health event occurs after vaccination does not mean it is caused by the vaccine. A rare, severe autoimmune reaction has been identified in women ages 18 to 49 that was not seen as a background health problem. The reaction occurs 6 to 14 days following vaccination, at which time women experience headache and or abdominal pain accompanied by a low platelet count and clotting of a large vein draining the liver, portal vein thrombosis, or the large veins draining the brain, cortical venous thrombosis. This complication has only been described in those receiving the adenovirus vector vaccines, AstraZeneca and Johnson & Johnson. Thrombosis is caused by the production of an antibody against a platelet protein called platelet factor 4, PF4, that activates platelets and induces blood clotting. This complication is rare, 1 to 2 per million vaccination, but is often fatal. If alternative vaccines are available for women in this age group, the adenovirus vector vaccines should be avoided. Keep in mind that COVID-19 is frequently associated with thrombosis as well as death. Therefore, the benefit of the adenovirus vaccines far outweighs the risk of this rare complication. Another rare side effect, 2.7 per 100,000 vaccinations, has been reported following mRNA vaccination, myocarditis or inflammation of the heart muscle. Symptomatic disease begins within 2 to 4 days of vaccination. The majority, 81%, complaining of chest pain, and 79% of the time there are electrocardiogram abnormalities. Symptoms usually occur after the second dose of the vaccine. Adolescent males ages 16 to 29 years are at highest risk. 76% of the cases are mild, and symptoms resolve within 2 to 4 days in most instances. An important question we need to answer is how long does SARS CoV-2 vaccine protection last? As shown in this graph plotting protection from hospitalization over time for the Alpha and Delta variant, the vaccine offers persistent protection for over 20 weeks. Note the flat curves indicating continued protection from hospitalizations over time. However, when it comes to protection against Omicron, as shown on these curves, immunity wanes more quickly. Those infected with previous variants and those receiving the vaccine have been shown to have lower neutralizing antibody titers to the Omicron variants and are less protected from contracting SARS CoV-2 infection. With the dominance of Omicron variants worldwide, a third dose of vaccine is now recommended for everyone. As will be discussed by Dr. Offit, a world-renowned vaccine expert, in a later video, when it comes to Omicron variants, 3 rather than 2 vaccine doses should be considered full vaccination. The third dose should be given 4 to 6 months after the second shot. For those 65 years or older, or individuals with serious chronic underlying diseases or receiving immunosuppressants, a fourth booster shot is also recommended. This dose is referred to as a booster shot because it is given to boost the immune response of those who are immunocompromised. Another important question we need to ask: should the booster contain sequences from specific Omicron variants? Without supporting data, the FDA answered this question yes, approving a booster containing both the ancestral or wild-type strain and sequences from the BA.4 and BA.5 Omicron variants, and termed a bivalent booster. It was theorized that adding sequences of the Omicron variants would enhance protection against the variants. However, as shown in this study by Wang et al., boosting with the original monovalent vaccine, blue circles, or the bivalent vaccine, red circles, results in similar protection as assessed by serum neutralization titers against the different Omicron subspecies BA1, BA2, BA4, and BA5, as well as BA4.6. Differences between the two vaccines were not statistically different, p-values varying from 0.13 to 0.97. It has been suggested this is the consequence of imprinting, that is, B and T cells predominantly react to antigens they have previously been exposed to, such as the ancestral or wild-type spike protein sequence, rather than process and react to new Omicron variant sequences. A very recent United Kingdom study from Moderna randomly administered the original vaccine or the bivalent vaccine BA1 formula as a booster. As the curves demonstrate, there were fewer COVID-19 events in those receiving bivalent vaccine. Estimated improvement in efficacy was small, 10%. The question arises, should we be periodically adjusting the vaccine given the minimal improvement in efficacy as compared to the original vaccine? Please watch the interview with Dr. Paul Offit, who discusses this important question. Recognizing the immunity will wane over time for those over 65, those with chronic underlying diseases, and those receiving immunosuppressive agents, experts recommend a booster be given once per year to maintain immune protection. Some of you are wondering, Dr. Southwick is calling for a third shot and in some cases a fourth shot when many in the world have not received their first shot, and inequity in vaccine distribution is a major concern. Until the entire world has been vaccinated, new variants with increasing ability to spread from person to person and evade the immune response will continue to arise. Therefore, developed nations must step up and help the developing nations, or we will never control the pandemic. The haves must help the have-nots. In summary, RNA lipid nanoparticle vaccines have an excellent safety profile, the major side effect being immediate hypersensitivity reactions, 2 to 4 per million. Adenovirus vaccines have one serious side effect, rarely inducing the production of an antibody that stimulates clotting of veins in the abdomen and central nervous system. mRNA vaccines have rarely been associated with a reversible myocarditis in adolescent males. With the arrival of Omicron, full vaccination will require 3 shots, 2 within weeks of each other, and then the third 4 to 6 months later. Boosters containing sequences from the Omicron spike protein have resulted in modest increases in efficacy as compared to boosting with the original vaccine. An annual booster is now recommended for those 65 years or older, those with chronic underlying diseases, and those receiving immunosuppressants. When it comes to controlling the pandemic with vaccinations, the haves must help the have-nots. We need vaccine equity.